Okay, let's continue. Okay, oh, see, I did it again.
Oh, you up at the top, start at current slide. Sorry.
Oh, that's all right. Almost there. Okay, so common oral throat and neck problems. I just kind of isolated to just a few things that I thought would be most commonly seen in a private practice or primary care setting. There's a bazillion other things I could have included, but I thought for the sake of time, I'll just focus on these items and we'll go from there. All right, so earlier in my health assessment class, I gave you a photograph of a dental anatomy. I'm not a dentist. I don't do a lot of dental procedures. Obviously, I've had dental work done to me, but you know, it's something I think is very helpful because if you want to identify if there's something wrong, the names of the different parts of the dental area would be very helpful. But I especially like the illustration on the right-hand side of what a dental decay and cavity and abscess would look like. And so this was a great illustration, so I thought this would be a good one to post up here too. Now, odontogenic infections are very common. 15 to 20% populations of mid to young adults are usually affected by periodontal disease in a severe way. And 25% of adults at some point would have had some form of dental problems, especially severe periodontal disease, gingivitis, and periodont caries as well. Especially because the concerning is if they're over 60 years of age, that would be a higher rate of that as well. Risk potentially of life-threatening complications by an infection would be if there's an abscess formation within the deeper spaces of the head neck because of the spread of the infection. Periodontal infection is also commonly associated with chronic conditions such as fetal development, microbial seeding into the heart valves on prosthetic devices, and then risk for coronary vascular disease and cardiovascular events. The spread of infection. Odontogenic infections originate from the plaque that's surrounding the teeth and the gingiva and can continue to colonize there, causing further destruction. So it typically starts with a plaque around the gingival, leading to dental caries, which invades deeper into the pulp, causing an infection and perforating the alveolar bone and causing an abscess. The plaque beneath the gingiva can cause periodontal infections, gingivitis, penetrate the fascia, space deeper into the head, neck, and mouth oral cavity area, causing deeper orofacial infection. The location of the infection between the bone and muscle and fascia, or muscle area, can predetermine the spread or the way the infection will continue to spread further out. So odontogenic infections, again, this is more of a visualization, again, of formation of the abscess underneath the tooth and how in between spaces it can continue to spread from the side of the gingiva and out. And if it continues to advance, it can go underneath and cause further damage to the bone around the maxilla. Specific bacteria that is associated with dental infections, these are names of bacteria that can be harbored and found in our teeth. The problem is if they start to penetrate and cause further damage. So just different names over there for you in case you've never heard of them before, like I have never heard of that either. So just kind of there for your reference. And then prevention of odontogenic infections, obviously, good teeth cleaning, flossing, routinely seeing their dentist for regular cleanings and checkups. There are patients who are at higher risk, and the use of fluoride paste or different types of fluoridation rinses are important in some of these patients. The use of chlorhexidine, I think, has been used by dentists in certain populations, but we don't need it on a regular basis. So it's not something that should be normally recommended for the average household. Okay. So certain behaviors such as smoking, eating a lot of sugary foods, not brushing your teeth, all of those things can be modified. We can teach and educate patients and counsel them the importance of good dental cleaning. And then over the last few years, I would say that xylitol gums have been found to also be of some benefit in reducing dental infections as well. to be chewed between meals. Okay. Therapy considerations include antibiotics for infections to prevent the spread and advancement of the infectious disease. Some concerns that you might have is, when is it appropriate to give somebody an antibiotic? So certainly if they're developing fever, lymphadenopathy, and swollen swollen lymph glands, if they're having some issues where you can tell that the dental infection is causing contact into the bony areas of the maxilla or the mandible, as well as additional swelling and inflammation. And if somebody's immune compromised, certainly you definitely want to put them on an antibiotic. There's less reliance on the collection of cultures in these patients unless there's an abscess and they're doing dental work and they haven't been able to figure out which antibiotic is working for them. I think a dental surgeon will actually do a culture, but you wouldn't necessarily want to do one from an oral cavity, because we have so many other contaminants in our oral cavity anyway. There's really not any usefulness in that regard. Penicillin alone is not recommended because it does not provide the beta-lactamase coverage. So treatment options by dental or other healthcare providers, I'm going to talk about that in the next slide. But erythromycin tetracycline not recommended because of the higher risk of resistant organisms. So those are not recommended as primary treatments. So we're going to go to the next slide. In here, you're going to look at, so it's kind of divided up. So this was actually a long sheet that I split up to fit into this presentation. So this would be the first column, this would be the second column. And that would just continue on. So what you're going to see is, with the type of infection that you would see, the most commonly known organism that's associated with those infections, and what would be the treatment recommendation for it. So if we start by something simple like the second one, gingivitis. Most common organism is streptococci, or actinomyces, or spirochetes. For this, penicillin would be appropriate, augmentin, or clindamycin. For something a little bit more serious like periodontitis, the adult periodontitis at the very bottom, you can see the names of the organisms there, and then the typical recommendation including doxycycline, metronidazole, minocycline, or doxycycline here too. So this just kind of gives you an idea. If you're seeing something you suspect and you feel really confident that you know what it is and you can treat that, these are the treatment options for that indication. Okay. Prophylactic antibiotics for dental procedures. There is lack of evidence to support the use of prophylactic antibiotics for prevention of endocarditis, according to the American Heart Association. There's still a constant debate about whether or not patients should be given prophylactic antibiotics before some type of dental procedure. But there is general consensus that there are high-risk populations who should receive antibiotic prophylaxis. These patients include those who have had prosthetic heart valves, who have a prior history of infectious endocarditis, unrepaired congenital heart disease, repaired congenital heart defects with prosthetic materials implanted, individuals who have had previous residual defects from heart disease and have other prosthetic devices implanted as well, or valve regurgitation. And antibiotics of choice for prophylaxis include amoxicillin, cephalosporins, clinda, azithromycin. So those are some options based on whether or not they're allergic to penicillin or not. Pharyngitis, oh my gosh, another very common complaint that people have. So pharyngitis is characteristically sore throat. Symptoms can vary, and it produces 8 million outpatient visits in the U.S. annually. Nearly 60% of these patients are inappropriately given antibiotic treatments when they shouldn't have needed it in the first place. Major goal with this in this patient population is identifying, differentiating, and prioritizing the seriousness of their disease, if whether or not it's infectious or not infectious, and to figure out the cause so they can reduce the incidence as well as reduce the severity of the condition and treat them properly. Pharyngitis, acute. sore throat, discomfort, trouble swallowing. The voice might become a little hoarse with that. Typically associated with a viral, bacterial, or candidal, or other forms of inflammation. Most commonly reflux disease. Chronic pharyngitis, typical symptoms would be frequent throat clearing, dysphagia, meaning trouble swallowing, odynophagia, meaning pain with swallowing, some inflammation, swelling around the back of the throat, and some hoarseness of the voice. Common causes include tobacco use, reflux disease, chronic allergies, as well as potentially a malignant process causing those symptoms. So always rule out a malignant disease before you consider any other diagnosis. All right, viral pharyngitis. Okay, obviously multiple viruses that could be causing pharyngitis, and these are all kind of listed in here. Just bear in mind, sometimes you can have co-infection of both viral and bacterial infections. Common viral causes include influenza. Characteristic symptoms, amongst others, include coughing, severe myalgias, hyperemia, fever. The only thing is that in this patient population, you will not see any purulence or white exudate on the tonsils. You won't see any of that. So that could be one clue that this could be more of an influenza as opposed to strep throat. Epstein-Barr virus, also commonly called infectious mononucleosis. Typical early symptoms are severe malaise, headache, low-grade temperature. As it peaks, they start to develop more pharyngeal symptoms, and they may often have severe engorged, inflamed tonsillitis, with or without the exudate, severe lymphatic, or the cervical lymphadenitis and enlargement, severe tenderness around the head neck area. Obviously, if it's advanced or it's progressed, they can develop adenitis, splenomegaly, potential rash. And so these hallmarks of the symptoms as they progress could be more characteristic for the Epstein-Barr virus. Cytomegalovirus is another viral infection, typically has prolonged fever, lymphadenopathy, with or without pharyngitis. And it's interesting that these patients with CMV have less pharyngitis than the Epstein-Barr virus patients. Okay, next virus, herpes simplex viruses, type 1 and type 2. Type 1 is 10% of these patients will have acute pharyngitis and or tonsillitis type symptoms. Often you'll see this in college students due to the herding of college students surrounded by others who are sick all the time. Severe pharyngitis may be seen with severe edema, tonsillar exudate, with or without exudate around the throat, and ulcerations in the oral cavity area. Oftentimes you'll see lesions around the throat, around the buccal mucosa and such. Now, type 2 HSV is a little bit more rare, and so it's often, they believe it's most often associated with oral genital contact. So HSV in the oral cavity, do not rule that out as being related to sexual contact. So just keep that in the back of your mind, because obviously the treatment for that will be a little bit different. But anyway, for treatment of use of oral antivirals is based on how severe their symptoms are. If it's very simple, just a little outbreak, you would typically expect that to resolve in a matter of a few days. However, if their symptoms are quite severe, it is appropriate to consider giving an antiviral. And the options that are out there are acyclovir, famciclovir, or valciclovir. Just depends on which one is covered by insurance and how much they can afford. Pharyngitis and primary HIV. HIV patients are prone to all sorts of illnesses, including typical pharyngitis. But with their history and their pathophysiology, pharyngitis is very common in them as well. So typically with these patients, they may or may not have a fever. Their their mononucleosis, they may mimic symptoms of mono, but not really have a positive lab test for mono. Have these vague symptoms of syndromes. They might have symptoms of aseptic meningitis. Other clear distinctive manifestations include mucocutaneous ulcers, shallow demarcated ulcers. I wish I found a picture of this. I was searching in the internet to try to find a picture of somebody with pharyngitis of this outbreak for an HIV patient, but I couldn't find one. But I'm just going based on the descriptions that they gave me here, that they would be well demarcated ulcers with white bases, a thin area around with film of red around the oral mucosa. So that's the only thing I can say. I've never seen it myself, so I'm just kind of going based on that. And I'll trust you with the rest of that. They'll have a lot of edema, redness, fever, fatigue, and all of that too. Typical viral syndrome. Bacterial pharyngitis, most common, of course, group A streptococcus. So about 5 to 15% of sore throats associated with strep. Typical symptoms include a sudden onset of a sore throat. You'll see the classic exudate and swelling and inflammation, tenderness around the cervical lymph nodes, fever. They may or may not have a cough, but again, it just kind of depends on the patient's symptoms at the time. Of course, with the group A streptococci, complications may include retropharyngeal or peritonsillar abscesses, rheumatic fever, and glomerulonephritis. Other bacterial pharyngitis include non-group A streptococci, typically not associated with acute rheumatic fever. Common symptoms of common cause for the pharyngitis seen in adults and college students. No antibiotics are necessary in this case. However, if a patient has really a known immune suppressed condition, it may be appropriate in that population to give an antibiotic. So, previously called Corynebacterium, what is now called Arcanobacterium hemolyticum, is a gram-positive bacilli. It is an uncommon cause for acute pharyngitis and tonsillitis, associated with adolescent young adults, mimics streptococci pharyngitis, and sometimes you will see a rash associated with this that resembles scarlet fever, but the cultures are typically negative for strep. Other additional common corynodiphtheria. Diphtheria can still be hanging around, hasn't been eradicated yet. General symptoms include pharyngitis, severe erythema, malaise, low-grade temperature. But the hallmark is the gray membrane that when you're trying to scrape it off or trying to rub it off, it can cause some bleeding, and it doesn't come off. Neisseria, gonorrhea, again, is also still prevalent and cause some pharyngitis symptoms. And it may be increasing in numbers, again, with people leaning towards more the oral sex behaviors. Chlamydia also can be more prevalent as well. Oral candidiasis, Candida albicans is the most common oral fungal infection, and that is a strain that is most commonly isolated. Associated with poor oral hygiene, the use of dentures on a chronic basis, people who have xerostomia, chronic and frequent use of oral antibiotics, or immune suppressed, such as HIV. Diagnosis based on history and exam. Cultures typically are not necessary. And then there's the debate of topical versus oral antifungals, and we're going to talk about that. Now, laboratory testing for forms of pharyngitis. I just learned this the other day, but there's a very special collection vial for isolating the influenza virus, and it's called a V-Flu-Nat to test for the influenza A and influenza B. If they're looking for some other form of viral strain, they can still use the same vial, but indicate to the lab that they're looking for anything other than influenza A or B, and they'll do additional panel testing for other viruses. WBCs may be indicated, especially if you're trying to determine if this is bacterial or viral in certain pharyngitis patients. And then also the heterophile antibody to check for mononucleosis, which is the blood test. The heterophile antibody turns positive after 3 or 4 weeks of the exposure or of the infection, so it may not turn positive right away if you were to test them at that point initially in the onset of the symptoms. If it's positive, you don't need to test any further because you know the diagnosis now. If, however, there is a risk of false positives in some patients who have systemic lupus, leukemia, gastrointestinal, gastric cancers, they may inadvertently test positive in these test results, even though they don't have mono. And then 30% of true Epstein-Barr virus infected patients may have a negative test result, so just be aware of that. And if it's negative, but you have a very high suspicion, repeat the testing a little bit later on. Okay. Throat cultures, rapid strep throat culture swabs. It's based on the enzymes that's extracted from the throat swabs that you do, and you get a pretty quick response, whether it's within a matter of hours or by the next day. It's 70 to 90% sensitive with a 90 to 100% specificity, strictly looking for the that particular bacteria. And the accuracy really relies based on how you do it. So we're going to talk more about that. Routine culture is gold standard, meaning you can do the rapid testing, but the gold standard is routine culture where they actually take the sample and they do the whole petri dish testing and they actually just wait for these things to grow naturally. They isolate what bacteria they've got. So use the gold standard routine culture as a backup if you think that there's a chance that the rapid strep wasn't going to process and there's that small window of chance that's going to be inaccurate. If, let's say, the rapid test is negative and patients are immune compromised, a routine culture is preferred in those patients. In the presence of, let's say, there's an outbreak in the community and you want to isolate if it's rheumatic fever versus viral or whatever, it's okay to do a routine culture as well, just to narrow down the possibilities and their differentials. The only problem is that when you do a routine culture, it can take 3 to 4 days to get their final result. So you just have to be patient with that, knowing that you have to decide if you are willing to wait before you treat or if you want a rapid test to kind of give a patient something empirically before you actually get the culture result. So you have to kind of make those decisions. Okay, throat swab collection and so when we were talking earlier about you have to really know how to do the collection properly to get an accurate study. So this is imperative that you swab a patient properly. So in doing so, make sure the patient is free of antibiotics prior to doing the culture results. So I generally recommend 3 to 4 days completely off of any antibiotics before you actually do it. And when you swab the patient, you have to vigorously swab both tonsils on the swabs on both sides. And try, if possible, to try the posterior oropharynx in the back of the throat. But I will guarantee you, you'll have a really bad gagging reflex doing that. It's hard enough doing the tonsil without the gag reflex, but you just do the best you can, be as vigorous as you can, be out of there as quickly as possible. But you do have to rub quite vigorously. And that just takes a little practice and trying to get used to working with patients who are severe gaggers. And you'll probably need to use the tongue blade to depress the tongue in order to expose the tonsil as well. And you'll have to have a good headlight or something of a good light source to be able to see back there too. And then once you collect it, make sure you use a proper collecting tool and the collecting vial that they provide for you, and then send it down to the laboratory. It's interesting that group A strep can still be able to grow, even if it's been sitting in the swab for 48 to 72 hours. It can dry up, but it'll still be viable. That's how strong it is. So it'll hold up for a few hours, even if there's a little bit of a delay in getting it to the lab. Okay. Now for the influenza collection, they want to use what's called the M6 media vial. It's a very different swab, very different medium that it stays in once you do the collection. But collection for the influenza swab, same technique, vigorous rubbing and the tonsil, and then just stick it into the medium and just send it to the lab. Okay, infectious mono, when you want to treat and manage this patient population, mainstay of treatment is supportive care. Acetaminophen, NSAIDs are fine. Hydration, nutrition, rest is very important. Some patients, if they're so swollen from the tonsils that it's affecting their airway and ability to swallow, it's okay to consider using the oral corticosteroid. Now, it's not recommended to be used on a regular basis. We don't recommend that. It's only in certain situations. And some of that could be because, again, the airway issues and difficulty swallowing and staying hydrated because of that. Okay. Now, Reye syndrome is a unfortunate condition that can develop as a result of the use of aspirin products when a patient is currently infected with a virus. And it includes mono, rhinovirus, influenza, varicella. If they use aspirin, some patients do develop this condition. And it can cause, unfortunately, some permanent damage, including brain and liver. Symptoms would be drowsiness, confusion, seizures, coma, or sudden death. So just be careful and make sure you educate patients while they're actively sick with a viral infection to avoid use of aspirin. but especially for somebody who's younger than 20, you really want to stay away from that. If they're an older adult, it probably won't, not as of a high risk, so it's not as pertinent at that time. And just make sure that you remember to teach patients that there's aspirin products in all variety of medications, and they can come under different names. Treatment for group A, streptococcus. So when you prescribe an antibiotic for this, you want to ensure that it's positive test on the culture, whether it's rapid strep or routine culture, before you start treatment. Reevaluate them in about 5 or 7 days to see how they're doing, to make sure they're improving or if they're getting worse. And consider whether or not, even though you may not know the culture results yet, if the patient has immune suppression or very complex medical comorbidities and they're quite ill from their other conditions, and you're concerned that if this might be strep while you're waiting for the culture, it would be appropriate to give an antibiotic in these patients. Avoid the use of sulfonamides, fluoroquinolones, and tetracyclines in the group A strep patients due to the risk of resistance with these medications. Expected symptoms should improve in 3 to 4 days of the antibiotic. If not, obviously you want to reevaluate to see what else is going on. And once they start therapy, they're no longer contagious after 24 hours. All right, so treatment, antibiotic options in this next handout, we'll see for treatment for pharyngitis due to group A streptococci. So obviously the main treatment option would be penicillin V, amoxicillin, cephalosporins, intramuscular injection of penicillin is also an option. And then if somebody's allergic to penicillin, your next options would be azithromycin, clarithromycin, or clindamycin. Okay. Treatment for non-genital mucocutaneous candidiasis. So we're talking thrush, oral cavity, excuse me, my stomach's going. Oral cavity candidiasis. So in these patients, their treatment options include clotrimazole troches, which are those little discs that they dissolve in the mouth. The only problem with that is you have to do it 5 times a day, which is a lot. So they may not be interested in doing that. Other options include nystatin, which is the swish and spit, but then that one you do 4 times a day. So I don't know, maybe 1 time less may not be so bad. But some people don't like the color and the flavor and the taste and texture of that either. But those have been proven to be very effective, but it's great if it's mild. But let's say if it's more severe than that, then the next option would be oral fluconazole, which is a pill that they can take once a day, I think, which should be very more compliant with using that. Next is for somebody who has esophageal oral candidiasis, that's a little bit more on the severe side, then an oral antifungal is appropriate, such as fluconazole. Okay. Management for pharyngitis, symptomatically, obviously hydration, throat lozenges. If they are really in pain, then oral analgesic is fine. Symptoms are typically short-term, and they really don't expect it to be long-term. If there's long-term, there's something else going on that needs to be further evaluated. Saline rinses and gargles are fine. Make sure you continue to encourage them to frequently hand wash and sanitize to avoid the spread of the infection. And then limiting their exposure to other people during the high peak of the incubation phase of the illness. Oral supplements or complementary therapies really have no place in this, as they're not really effective. And then observe for any risk of fever, dysphagia, airway compromise, drooling, where the point that they also can't talk. You want to look for any serious problems, including the hot potato voice that I was talking about before, and someone who has really bad airway issues with peritonsillar abscess. Okay, deep neck space infections. Just a few things that may be of pertinence and importance. Submandibular space infections, also called, kind of a generic name, also called Ludwig's angina. This is a very tender, swollen, inflamed area of the base of the floor, where it's so swollen it starts to swell up from underneath the tongue, and potentially could push the tongue up towards the airway and compromise the airway and cause obstruction. It's very serious, and it requires immediate evaluation. And then retropharyngeal space infections, actual infections that are deeper into the neck causing really severe airway compromise as well. Epiglottitis, I did talk before earlier in our assessment class, where the epiglottis is severely inflamed, most commonly due to the Haemophilus influenza virus or bacteria, and it affects the airway, most commonly seen in children, but the vaccines are helpful in minimizing that now. Peritonsillar abscess is a deep space abscess that's above and behind the tonsil, where this is not the same as tonsillitis, and this is the actual formation of an abscess deeply rooted in the retropharyngeal area that can cause severe issues with airway, breathing, swallowing, and severe pain. And so these patients actually need to be seen by ENT as soon as possible. Now, managing the peritonsillar abscess. Most common bacterial organisms are streptococci, streptoridians, Neisseria species, as well as anaerobic gram-negative species. Antibiotic choices include clindamycin and augmentin. They often will benefit from taking some form of analgesic. When their pain is so bad, you may need to give them a narcotic just to manage the pain. And please refer to ENT, as it probably needs to be drained with the incision and drainage. Likely a culture will be obtained to make sure they are targeting the therapy correctly. And if patients have recurrent problems of this or really bad tonsillitis over and over again that leads to the peritonsillar abscess, they probably won't require a tonsillectomy evaluation. Further pharyngitis and neck infection tips for you to be aware of. Just a few mishmash of miscellaneous things here. Viral infections, most often prevention is the best bet. So there's a lot of immunizations out there now to help prevent the risk of the viral infections. For patients who are actively sick, let's say the influenza or one of the other viral infections, Tamiflu is an option that's out there now. There's pros and cons to everything, so it's worth for you to investigate the pros and cons and benefits and risks of being on the Tamiflu and providing that for a patient. In our ENT clinic, we don't provide that because it's all usually given by the primary care provider, so I don't have as much experience with that, so just something for you to be aware of. If, however, there's airway issues, stridor, severe dehydration from fever, nausea, vomiting, poor oral intake, you may need to consider sending them to the ER for IV access, hydration, further evaluation. And then refer to ENT for surgical management if, again, tonsillitis recurrently or chronic pharyngitis, dysphagia, weight loss. And so there's something, a few things to keep aware of. Just a few things about managing a patient who's constantly asking you for an oral antibiotic, and this could be for the ear problem, nasal sinus issue, or throat problem. They want to walk out here, and they're not going to go out until you give them a prescription. Some things that you might want to be aware of is that the American College of Physicians recommends counseling, and educating the patient about the risks of resistance and overuse of antibiotics, and they don't understand that. They're miserable, they just want to feel better, and they expect to get an antibiotic. So you have to explain, this is what you have, I think you have a viral condition, and you have to explain that there's no benefit in taking an antibiotic. We just do the symptomatic management that we talked about earlier today. The other thing is, sometimes patients don't understand, and sometimes what can happen is if you change the wording or revise the diagnosis to something a little bit more commonplace that they might be better able to understand. So supposing they have a viral rhinovirus, instead of using that fancy word, just tell them, oh, you have a viral inflammation or a viral sore throat. So try not to use anything too technical, but make it more symptomatic, that these suggestions that you had for comfort measures and self-management is better able to manage those symptoms better. Having handouts available with proper education about antibiotic overuse versus other self-care measures. Walking out with something is really helpful for patients. Whether they read it or not is a different issue, but hopefully they'll be able to pay attention to that. But if you spend the time and the effort, it really does help in the long term too. And then, as I said before, a lot of patients just need some reassurance that, how long do I need to wait before I call you? Because I'm afraid I'm not going to get any better when I walk out this door. So if you tell them, you've been sick for about 4 or 5 days now, let's give it another 5 days. Let's wait until the weekend. Call me if you're worse. If you're not feeling better, then we'll talk and we'll reevaluate, and reassure them that if by the 10th, 12th, 13th day after the onset of their symptoms, when you call them, if you're still not better and you're actually getting worse, I will likely give you an antibiotic at that time, but let's give it some time. Because if you're feeling better, that means it was a viral infection. So if they have that backup plan, if they know that you have something else in store and something else in mind, it gives them some reassurance and they feel like, oh yeah, so they already have something in mind and I can feel comfortable walking out of here now, instead of insisting on walking out with an antibiotic prescription. Next thing is dysphonia. Laryngitis is a very common, most common causes are viral, bacterial, or inflammation. Hoarseness is very common and prevalent in almost 30% at some point in all of our lives. The greatest population are individuals who are chronically using their voice all the time, singers, actors, professionals who are always on the phone, customer service agents who do nothing but phone work all day long. Women are more common than men. The trouble is that when they have chronic laryngitis or they can't talk and they have voice issues or they have loss of voice for a prolonged period of time, it creates other side effects such as social isolation, depression, and it reduces their ability to kind of continue on with their life because they feel like they're just kind of withdrawn from the world. Okay. All right. So in this busy handout here, this is a long list of different possibilities for hoarseness. I gave you a short list during the health assessment class. This is a long list. So there's tons of stuff that could be there. Just keep that in the back of your mind when you're assessing a patient. Conditions that are suspicious for a serious problem. This is a little bit more important because you have to look out for any history of tobacco use, trauma, hemoptysis, meaning coughing up blood from their throat area. Those are a little bit more concerning. You need to be looking out for those possibilities and make sure you're asking. Even unexplained or unwanted weight loss is a trigger that you need to be looking out for, a possible cause for carcinoma. Medications that can cause hoarseness. Yes, there are drugs that can cause hoarseness. So thrombolytics, antihistamines, oh yeah, antihistamines are known for drying up mucus and secretions, and so some people can have thickened mucus secretions and actually feel like they're dry, and it can alter their voice a little bit because of the dry mucosa in the larynx. And so that can cause a lot of changes. Even hormonal fluctuations can cause that too. Management of dysphonia. Anti-reflux medications have no role unless they're proven to have reflux disease on history and direct exam. You should not be routinely giving reflux medications for voice changes. Do not routinely give antibiotics or steroids for this indication unless there's an underlying medical condition that they would warrant those. Diagnostically, an ENT should evaluate all patients with dysphonia or voice changes for risk for malignancy, lesions, any form of vocal fold weakness to be evaluated. So please make sure you refer the patients to the ENT. Consider the following options after they've been seen by the ENT for a visualization. CT or MRI for patients with hoarseness if there are any concerns for serious disease. And you may consider prescribing anti-reflux if they've been positively affirmed to have reflux disease based on the ENT's evaluation. A lot of times the ENTs would have explained that to them and probably would have offered it to them anyway. But unless there's some strange reason the ENT saw them, had shown that there's a reflux and they never prescribed anything, it's okay for you to consider offering them a prescription for that. Speech therapy is strongly recommended in patients with dysphonia or hoarseness. And as it can definitely improve the quality of life and outcome. Neck mass and lymphadenopathy. Neck mass in a patient who's over 40, always assume it is a malignancy or carcinoma until proven otherwise. Okay, so it's very important. Anytime you find a mass anywhere, always be suspicious and have that further evaluated. Pain is most likely infectious or inflammatory process, and the neoplastic masses are most often asymptomatic. There's typically no pain associated with that. So that would be an alarm bell running off the top of your head. Patient doesn't complain of any pain, so they don't bother telling you, but you're seeing them for a different reason. You find something as an incidental finding, you see a mass, you feel a mass, they're not complaining of anything. That's got to be a little red flag right there. Voice changes, hoarseness, trouble swallowing. unilateral otalgia or a one-sided ear pain that's been persisting and gradually getting worse over time, always consider that to be a malignancy of some form until proven otherwise. Fever, night sweats, weight loss, again, be on the lookout for any concern for lymphoma or other issues. Tobacco use, alcohol use, other forms of illicit drugs can also increase the risk of lymphadenopathy and potential carcinoma. Characteristics of a mass. I thought this was very helpful because how do you describe a mass and how do you know what it could be? And so I kind of listed this as inflammatory or reactive lymph nodes are often just isolated or discrete. They can be mobile, they can be described as firm or rubbery, but sometimes are often a little bit tender, especially if it's inflammatory. If it's infectious, it's typically very warm, very tender, and very fluctuant. If it's something more of a mass, like a cystic congenital mass, it would be kind of what we call volatile, which would mean if you push down on it, it would just kind of bounce right back. So volatile, mobile. Let's see. Vascular lesion. If you feel it, it would be pulsating, correlating with the pulse. Okay. Pulsatile quality or brewy to that. Malignancy would be hard and it would be fixed and attached to the surrounding structures. So different descriptions that might be helpful for you. Congenital neck masses are typically present at birth, but in some conditions they may even continue to persist or develop later with age. And the list right here is just a few of the different congenital neck masses. You may or may not ever see any of these, but the more common ones are brachial and thyroglossal cysts. So brachial cleft cysts is a collection of cystic material that develops in the cleft, in the small cleft that's left behind. So when we're in our embryonic developmental stages, we have these different structures that start to formalize into different structures around our neck. So we have these early pockets of clefts, and then they develop into the other anatomical structures. But in some patients, those cysts remain behind. And so what happens is you start to develop all these little materials up in these pockets that grow and develop and collect all this material. And they can kind of continue to develop. And so there's different areas that they can have that, and I'm going to show you a picture of that. And they can also cause recurrent infections, even if they're a child or even as an adult if they still have it. Some people may have never known they have this until they develop an infection. Something that you should be aware is that carcinomas of the tonsil, tongue, and thyroid can sometimes mimic these cystic neck masses. So again, keep those as a possible differential. So the management of these cleft cysts, let's say if they're actively infected, you can consider an antibiotic, but oftentimes it's more, if you find it, isolate it. If they're having recurrent problems with this, just refer them to an ENT doctor, because there's a lot of complicated issues with treating and seeing a patient with this. So just refer them to an ENT to have them manage that. Okay. Now, so here's an illustration of a brachial cleft cyst. So you can have a cyst here just below the ear, under the jawline, just a little bit more midway down the lateral side of the neck. And you may not see or feel anything unless it's starting to fill up and cause an infection. Okay. Now, thyroglossal duct cysts are remnants of the thyroid gland that after the thyroid and all the surrounding structures have formed, there's a little pocket or a little cyst that stays there. It can fill up and get a little bit enlarged. And it would literally be in the midline. I'll show you a picture of that too. Oftentimes you'll see this in children. It's unlikely it'll continue on as an adulthood unless they're in a third world country with no access to medical care, because you would see this as a child and usually get that taken care of before they become an adult. But this is something that's only, again, managed by an ENT. So if you ever see this in a patient, most likely children, but if by chance you see an adult who still has this, refer them to an ENT. And so this thyroglossal duct cyst can actually form literally right in the anterior midline, right around the thyroid, or above the thyroid as well. And it can actually it can be small and get a little bit bigger over time. It just filled with fluid and pus and other material, but it doesn't necessarily mean that it's infected. Okay, it just needs to be drained and surgically removed. Causes of peripheral lymphadenopathy. Okay, so lymphadenopathy is our next section. Different causes, obviously, for why somebody has enlarged lymph nodes, and different causes for bacterial, viral, infectious process, obviously cancer, lymphoma, and spread of the malignant disease, as well as immune suppression, endocrine disorders, as well as other conditions such as Kawasaki disease and eosinophilic granulomatosis. Oops. All right, so metastatic neck masses, predominantly squamous cell carcinoma is the most common cause for metastatic neck mass in the aerodigestive tract. The metastatic nodes in the posterior triangle, which would be along the upper and back portion of the neck right here. When you're doing the lymph node assessment, that would be the area that you're looking for any masses that would suggest metastatic disease. Lymphadenopathy along the upper jugular chain from the oral. Okay, so if somebody has a cancer in the oral cavity or a pharynx and larynx, usually will cause the lymph nodes along the jugular chain down here to enlarge. So the disease is spreading now down to the lymph nodes around that area. Let's say if somebody has a cancer in the tracheobronchial, distal esophageal, or stomach carcinoma, those cancers will spread to the lymph nodes along the supraclavicular region down here. An overall approach to the examination of the neck. So another algorithm. So you see somebody with a neck mass, you do a thorough history and physical. Based on history and findings, you're positive as a carcinoma, send them to a surgeon. Let's say you're not quite sure yet, you want to further evaluate. Either you wait it out to see if it's infectious and it gets better or not, or you decided to pursue further evaluation. If you want to try an antibiotic in case it's an infection, go ahead and try that. Wait for a week, reevaluate if there's no improvement. Diagnostic options that we're going to discuss now and what you can do to evaluate that. Okay, so lab tests include CBCs to see if there's any anomaly or abnormalities that you can find on there. ESR, CRPs, blood cultures, any viral serologies and HIV serologies to rule out any of those other medical conditions. If there's order the following tests if there's any indication of any of these conditions. And again, these are pretty rare. And I've never ever had to order any of these, including Bartonella for cat scratch fever or tuberculin skin test, which of course I think pretty much everybody, you have to be suspicious of TB because that is starting to come back around again. So just be aware of that. And then imaging studies. Okay, so CT of the neck with contrast is the standard for the neck if you want to image somebody with a neck mass. MRI would be the secondary one, and then ultrasounds. Advantages of ultrasound is it's non-invasive, it's real time, you can do it right then and there. And plus ultrasound is really helpful in guiding the FNA collection for a sample, and it's very inexpensive. Disadvantages that it requires proper training, expertise of the person who's doing the technique, and it's limited by the fact that it doesn't really tell you as much as you might want, but you have to kind of use it as a resource to guide your decision on what to do next. I don't know if that makes any sense, but we'll kind of talk a little bit more about that. Ultrasounds for thyroid nodules. In 2015, American Thyroid Association came up with a little bit more specific guidelines. So thyroid nodules would be a fairly common thing that you might see in primary care practice. So typically you want to start with ordering an ultrasound of the thyroid and neck as your first line imaging study. And that will kind of tell you based on the imaging findings, but when the radiologist interprets that, whether or not it's suspicious or not suspicious. If they find that it's suspicious and they recommend a fine needle aspiration, they'll suggest that. The indications for repeating an ultrasound is if there's, if let's say the FNA, you cannot do an FNA in a certain patient because of a health problem or they're on anticoagulant therapy, there's increased risk of bleeding with doing that procedure. So you can repeat the ultrasound in the future without doing any FNAs. And if they say there's suspicion of growth or changes or characteristic concerns for carcinoma, then they would suggest imaging or referral to an ENT. So different recommendations for that. So if I needle aspiration is a preferred diagnostic approach for most neck masses. The benefits is less invasive, it's safe, does not require any anesthesia, and it's 85% or more accuracy. Limitations are it does induce some pain and discomfort, but they usually do provide a local anesthetic. It is fairly accurate, depending on the skill of the provider who's collecting the sample. Whoops. And it should be done by direct palpation, and sometimes they use CT to help guide where it's located and how far they should use the needle to aspirate. So it's all technician related and their technique and how it's collected. So it's kind of variable based on that. So there's some question about if it's really going to be accurate or not. But the analysis of what they find on there could include certain words like blood or purulence or viscosity. So just different terms that you might see in the interpretation. Indications for what's called an excisional biopsy, which means you're actually sending the patient to the ENT surgeon for them to do an actual incision and collection under surgery and general anesthesia. So the reasons for this would be if using the FNA is not indicated, or if they try the FNA but it was unsuccessful, or the patient wasn't tolerating it well, if they were trying to attempt the FNA, or the FNA is negative or inconclusive, and they need a more definitive diagnosis, then you send it to an ENT and they will consider doing that. So oral cavity cancer screening is something that we often talk about in ENT. So the questions here is, should we be screening everybody? No, not necessarily. So the few things that the U.S. Task Force, U.S. Preventive Task Force suggests is that if a patient is over 18 years old and there's no risk factors, you don't have to be screening everybody. But if they have risk factors and they have, let's say they're smoking, they have tobacco, they have family history, or something else that suggests that there is some concern if they're over 18 years old, by all means, feel free to go ahead and do a quick screening. And that would be just getting a general history of potential exposures, any family history problems, any issues symptomatically that may be having to suggest some type of oropharyngeal or a neck type of lesion. So it's okay to screen for them. And in my case, I generally do anybody who's older, even without them knowing it, I'm already examining them. I'm just in the general health history. I'm listening to their voice. I'm talking to them, listening to what they sound like. I kind of inquire and ask a few more questions about, oh, by the way, do you have any trouble swallowing? Have you been losing weight? Just a very brief, it doesn't take that long to do a history on that. And then also by looking around the ear, nose, and throat and feeling around the neck, I'm already visualizing and screening already as it is. So they don't even know it. Okay, now we're near the end. And these are just my references. And I wanted to put them in alphabetical order, but then at 10:30 at night, I decided to forget about it. So I just kind of thrown it randomly. So the anal retentive side of me wanted to do that, but I was like, oh, forget it. So, all right, so any questions for this last section? Nope.